Welcome to another episode of Diabetes Care on Air, a new and a different way to bring the research in diabetes care to life. Today, we are featuring the content of the February 2023 issue. For those who are new to the series, my name is Dr. Alice Chang from the University of Toronto.
And I'm Mike Rickles from the University of Pennsylvania. We are your co-hosts for this podcast.
So, Mike, did you notice the beautiful artwork that was on the cover of the February 2023 issue?
Yes, Alice. This month's cover exhibits a powerful drawing by a young artist, Jaisra Chaudhry. Ms. Chaudhry created the artwork in response to the increasing cost of insulin that continues to add to the enormous burden of living with diabetes for so many of our patients. Ms. Chaudhry donated this inspiring art to the University of Washington Diabetes Institute and now to this month's cover of Diabetes Care. I encourage each of you to have a look. Ms. Chaudhry's liquid gold imagery is unforgettable.
Yeah, it really is quite powerful. And I absolutely love the idea of featuring original art by someone affected by diabetes. So we encourage all of our listeners to spread the word. And if someone is interested, please email the ADA at productionmanager@diabetes.org or visit the Diabetes Care website for more information. Sadly, Mike, I have absolutely no artistic ability, but I know that there are many talented people out there, and I look forward to seeing what is submitted.
Before we get into our interviews with some of the authors from this issue, I want to highlight some very special content this month. The National Clinical Care Commission was a federal advisory committee charged with leveraging federal policies and programs to more effectively prevent and control diabetes. Its recommendations to the U.S. Congress are included in the February 2023 issue of Diabetes Care in the form of 5 articles. For those of you who wish to learn more about this important topic, we will be having a special episode coming up dedicated to this report.
And if I may add, I'd say that although the Commission's report was obviously focused on the American healthcare system, there are commonalities and learnings that certainly could be applied to other countries. So definitely well worth the read and or listen.
All right, Alice, let's jump into our first author interview. One of the feature articles in the February 2023 issue of Diabetes Care is a perspective in care titled Brain Glucose Sensing and the Problem of Relative Hypoglycemia. This is a topic I'm personally fascinated by, and so I'm thrilled to introduce this paper's first 2 authors who have joined me to discuss these concepts and the supporting evidence. Dr. Michael Schwartz is the Robert H. Williams Professor of Medicine in the Division of Metabolism, Endocrinology, and Nutrition at the University of Washington, where he co-directs the UW Medicine Diabetes Institute. Dr. James Crinsley is Professor of Clinical Medicine in the Division of Pulmonology and Critical Care at Columbia University and former Director of Critical Care at Stanford Hospital in Connecticut. Welcome, Mike and Jamie, and thank you both for joining us.
Happy to be here. Thank you.
Pleasure to be here.
First, congratulations to you both and to your co-authors on this feature article. Your article really covers 2 important and related concepts. Let's start by discussing brain glucose sensing. Your article challenges the model that glucose levels are sensed by neurons in the brain and instead proposes an alternate blood glucose sensing model where blood glucose concentrations are sensed by peripheral neurons innervating the vasculature that communicate systemic levels to the brain. Can you please elaborate on this distinction?
Sure. I would modify what you said just a little bit, in that I do think that glucose levels in the brain are being sensed, but I don't think that's the major determinant of the role of the brain in glucose homeostasis as far as glucose sensing is concerned. So to say it differently, I believe it's more likely that the brain is continuously being apprised of the glucose level in the circulation in much the same way it's being apprised of the blood pressure or the body temperature or any of a number of other homeostatic variables, and that it can respond quickly to changes in the circulating glucose level without the need for a change in the level in the brain to have occurred. And to take that a step further, part of the goal of this homeostatic system is to keep the brain glucose supply and the glucose level constant. So if you needed a change of brain glucose in order for the system to work properly, you would end up with a system with the brain glucose levels changing more or less continuously, which I think is unlikely. In fact, the data show that that isn't true.
Great. That really helps me conceptualize this a lot, Mike. So your article points out how sustained hyperglycemia can lead to a reduction in glucose transport from blood to brain. Is it possible that reduction in brain glucose transport may be adaptively protective against hyperosmolality affecting the brain? Or is this somehow involved in blood or brain glucose sensing mechanisms?
That's a good question, and we really don't know the answer. I think when it was first shown that sustained hyperglycemia appears to reduce the efficiency of glucose transport from blood to brain, it was assumed that meant that the brain didn't measure glucose properly in response to high blood sugars or hyperglycemia. But as I mentioned earlier, I think that may be a bit of a sort of an epiphenomenon that yes, it's true that the efficiency of glucose transport does appear to be reduced, but I don't think that is very important in how the brain is sensing the circulating glucose level. So what is the consequence of reduced glucose transport into the brain? Possibly it is serving a homeostatic role to protect against hyperosmolarity, as you suggested, or it could be that it's sort of a backup or fail-safe mechanism so that if the peripheral sensing input isn't working properly, then the brain transport and the actual brain glucose level becomes more important.
Great. And following up on that, Mike, there's a well-described hierarchy to the glycemic thresholds for activation of counterregulatory responses. And as we know, first comes the islet, which expresses its own glucokinase and beta and alpha cells, and that responds by turning off insulin and turning on glucagon secretion. And then next come the brain-dependent responses, epinephrine secretion, typically activated by about 65 milligrams per deciliter, then growth hormone and cortisol by 60 milligrams per deciliter, and then finally symptoms are recognized by 55 milligrams per deciliter. How do you think these normally differing glycemic thresholds can be explained by blood glucose sensing?
Well, I think the blood, it's again, if you use thermoregulation as an analogy, the brain is being provided with continuous afferent information from the periphery about the environment, both internally and externally. And I think that's true for the glucose level. And if the glucose level drops to a level that is, activates these counter-regulatory responses, those responses are initiated in decrease of the glucose sensing in the periphery. That activates a network, a central network that is connected to all those responses that you mentioned. And the fact that the thresholds differ simply has to do with how much of a signal do you need to generate in order to get one response to occur as opposed to another. And I think this also applies to the behavioral component to the extent that the behaviors you're talking about are manifestations of adrenergic activation. I think if you're talking about cognitive impairment or changes of consciousness, that probably is more of a decrease of brain glucose availability, not just a signal that the glucose level is low in the bloodstream.
Thanks, Mike. I think that's fascinating. So blood glucose sensing is there initially to sense and alert the central nervous system to changes in blood glucose, hopefully then allowing compensatory mechanisms to prevail prior to the brain being deprived of glucose or seeing an excess of glucose that could be detrimental. And I think that concept of thermoregulation is terrific. And also this fail-safe relegation of what's being sensed within the neurons that's potentially the backup, as you say, to what is normally a continuously sensing and responsive of the nervous system to maintain glucose homeostasis. That's just fascinating. I'd like to move on now to this problem of relative hypoglycemia. And your article reviews evidence that during critical illness, hyperglycemia is associated with increased ICU mortality for patients without diabetes. And that makes sense to me. But also, you review evidence that higher glucose is associated with lower mortality for patients with diabetes who have an elevated hemoglobin A1C prior to their hospitalization. Can you explain this apparent paradox?
Well, thank you, and I appreciate the opportunity to participate in this podcast. I think we should take a step back for the people listening because they might not be aware of the long literature relating to the intensive insulin therapy randomized controlled trials and where we got to where we are right now. So back in 2001, the landmark trial, single center, looked at surgical ICU patients and randomized them to a target of 80 to 110, which was defined as euglycemia, compared to a much higher liberal target, and found a reduction in mortality and morbidity. A number of subsequent randomized controlled trials were very uneven in their results. And in fact, the largest trial, published in 2009, the NICE Sugar trial, actually showed an increase in 90-day mortality in the patients randomized to the intensive arm. Now, importantly, all patients in these trials on the interventional arm got the intensive 80 to 110 target. So regardless of pre-admission glycemia, they were treated intensively to 80 to 110. In the last several years, the relationship of acute and chronic glycemia has been explored in a number of observational studies. Acute glycemia is ICU glycemia. Chronic glycemia is usually defined by the surrogate of hemoglobin A1C. Our group in 2020 published a 5,500 patient study from a single center observational database study demonstrating that for patients with hemoglobin A1C less than 6.5%, as mean glucose in the ICU increased, mortality increased sharply, actually by a factor of 3.5 from the lowest to the highest increment. Whereas for patients with hemoglobin A1Cs greater than 8%, mortality actually went down as mean glucose during the ICU stay went up. We believe that this may be in large part due to a combination of absolute or even relative hypoglycemia. We define in the critical care literature absolute hypoglycemia as glucose levels less than 70, which I think is pretty consistent with the endocrinology literature. Relative hypoglycemia has been defined a couple of ways. An Australian group defined it as 30% reduction from estimated pre-admission glucose using the Nathan formula, which translates hemoglobin A1C into a mean pre-admission glycemia. Our group published in 2022 a study of relative hypoglycemia, which we defined as incursions into the range of 70 to 110 for any patient with a hemoglobin A1C of 8% or higher. And we found that for these patients with hemoglobin A1C of 8% or higher, if they stayed above 110, their mortality rate actually amazingly was 0%. But if any incursion below 110, even without absolute hypoglycemia, was strongly associated with death. Now, that's what relative hypoglycemia is. The glucose level that would be considered normal in patients with normal baseline glycememia. And importantly, remember that the interventional arms of the randomized controlled trials were treated to a target of 80 to 110. So we believe that it's possible that many patients in these trials, could have been harmed by the intervention. Now, do we know why people die who get into the relative hypoglycemia range? No, we don't. We don't have any exact correlation between the event and death. In the ICU, most patients are dying of multiple organ system failure or overwhelming injury, such as head injury from trauma or stroke. And it's hard to correlate these glucose levels with approximate event leading to death. And of course, you can't randomize a patient to hypoglycemia or any other type of malglycemia. So we have to depend on observational data to make inferences.
So Jamie, that's really interesting. So what we talked about previously with blood glucose sensing, alerting the central nervous system to induce counterregulatory mechanisms, these include stress responses that have been associated with relative hypoglycemia. And I know that it's hard to differentiate these from other stressors, as you point out, occurring in the context of critical illness. Are there ways you can imagine us teasing out the importance of avoidance of relative hypoglycemia for patients in the ICU as we move forward?
I believe that the future must hold the idea of performing a randomized controlled trial based on personalized glycemic control using pre-admission glycemia. And our best metric right now seems to be the hemoglobin A1C level. Such a trial should avoid hypoglycemia in both forms, absolute and relative, as well as achieve adequate degrees of glucose separation, meaning that the control and the interventional arms would have different levels of mean glycemia. And if we were able to perform such a trial, I think that would prove the point that relative hypoglycemia is deleterious in the critically ill. It wouldn't necessarily prove the mechanism of why that is occurring. And to get to that degree of granularity, I think would be a difficult task. Perhaps it would involve taking a very close look at the last 24 to 36 hours of a patient's stay in the ICU following an episode of relative hypoglycemia and making a number of physiologic measurements. Certainly that sort of detail isn't available from large database investigations, retrospective.
And Jamie, to get to such a trial and perform measurements that can be robustly compared between targeted interventions, will continuous glucose monitors help us in this current era for the next series of clinical trials addressing this topic?
That's an outstanding question. I believe that one of the reasons why the previous RCTs have not been successful is that glucose, frankly, hasn't been monitored adequately. Even in my ICU, we are making anywhere from 7 to 10 measurements per patient per day, and that is far in excess of most published studies. I think CGM holds the potential to lead to a successful implementation of a trial because, if you're trying to achieve multiple targets, having the continuous feedback of the glucose levels will be crucial. And you'd get glycemic separation, and there's a high likelihood that we would avoid hypoglycemia with CGM. So I'm very optimistic about its future in the ICU.
That's great. Thank you so much, Jamie. And finally, what other takeaway messages do you, Jamie, or Mike have for our readers?
I guess what I would say is, first of all, the hypothesis that we put forward here about both how the brain senses when the glucose is too low and what might be leading to relative hypoglycemia mechanistically, if peripheral or glucose sensing of glucose in the circulation rather than in the brain is actually what is normally being monitored and what normally drives responses to hypoglycemia, at least initially, then you can potentially explain the phenomenon of relative hypoglycemia as a result of this peripheral afferent sensory system not working properly. So hyperglycemia dampens the ability of the glucose sensing neurons that are processing and presenting this information to the brain. It dampens their responsiveness to glucose. So it takes a higher level of glucose to get the same response. And this is actually the same thing that happens in the pancreatic beta cell setting of hyperglycemia, which has been reported many times now in the diabetes literature. So I think there's an argument to be made that the sensing process is dampened by hyperglycemia. So the brain thinks that the blood sugar is actually lower than it truly is because it can't sense it properly. And so the threshold for hypoglycemia responsiveness is elevated as a consequence of that. So the first thing I want to say is that that's a hypothesis. We haven't proven it yet. But when you do a deep dive into the various possible explanations, that's the one to our group that makes the most sense. The second is that if that's actually true, and if there are interventions that could restore proper glucose sensing, both in the nervous system and in the pancreatic beta cell, a lot of this problem just goes away because it's really being driven by an impairment in glucose sensing. That's one of the implications of this model and why we wanted to get it out there for members of the community to think about.
My takeaway message is a clinical one. I would say that following the 2009 publication of the NICE Sugar trial, there has been a degree of apathy among clinicians regarding glucose control in the critically ill. I'd like to say that this apathy is not correct. It's crucially important. And I believe that the future will be of personalized control rather than one size fits all.
Thank you, Mike and Jamie. This has really given me for sure a lot to think about, and conceptualizing this concept of peripheral blood glucose sensing, how it relates to brain glucose sensing, and consequently, how relative hypoglycemia can be detrimental for our patients, particularly those in the ICU. I really appreciate your taking the time to share your expertise on these topics with us today. I know I've learned a great deal and will bring a new perspective on glycemic control and targets with me to each patient that I see in the ICU. I want to thank you, Dr. Michael Schwartz and Dr. James Crinsley, and our listeners, who I encourage to access the full article in the February issue of Diabetes Care.
One of the feature articles from the February 2023 issue of Diabetes Care is titled The Impact of the COVID-19 Pandemic on Ethnic Minority Groups with Diabetes. And to discuss this important topic, I am super excited to be joined today by none other than the Professor Kamlesh Kunti, Professor of Primary Care Diabetes and Vascular Medicine at the University of Leicester in the UK, and one of those people in diabetes who's famous enough that he could actually be referred to just by his first name, kind of like Cher or Madonna. You could just tell a colleague, I'm going to go chat with Kamlesh, and everyone will know who we are talking about. So thank you very much for joining us and joining on the show today, Kamlesh.
Pleasure. Alice, it's great to be on here.
And actually, before we dive into the paper, I'm going to embarrass you a little bit. I also wanted to extend my congratulations to you for being awarded a CBE in the UK. So you're a Commander of the British Empire. I sort of Googled exactly what the CBE stood for. So congratulations to you for achieving this incredible milestone.
No, thank you very much. Yeah, a really proud moment. Not sure what it means, but yeah, it's still a proud moment.
So let's dive a bit into the article at this point. And the topic here is the COVID-19 pandemic, which obviously has had a tremendous impact on the world over the last 3 years. And you have played an important role in helping us understand the relationship between COVID-19 and diabetes. So maybe let's start there. Can you briefly summarize for us the current understanding of the relationship between COVID-19 and diabetes?
Yeah, sure. I mean, the data on diabetes came very early on. I think one of the big papers was from the UK Open Safety Database that showed that diabetes was one of the big risk factors, as well as other chronic conditions that were associated with increased risk, but also increased mortality as well. You know, all of us, when the pandemic came through, thought this is going to be a respiratory disease. But suddenly it became very clear it was a cardiometabolic condition more than anything else. And that's why I got very excited and got involved in it. And very early on, again, we started work because we have some of the best national data sets in the UK, and working with our national director, Jonathan Walji, we showed very early on the whole population of England, where, as you know, we get free service in terms of medical care and medications. And still, despite that, people with type 1 diabetes, there was a 3-fold increased risk of mortality. Type 2 diabetes, 2-fold increased risk of mortality. And suddenly, all the signals were there that this is not going to be a good thing for people with diabetes.
Mm-hmm. So definitely a relationship between COVID-19 and diabetes that we had to understand. And some of the data also highlighted the differences in consequences of COVID-19 based on populations, age, socioeconomic status, and ethnicity. But these differences based on these parameters, especially around ethnicity, actually existed, especially for diabetes care, even before COVID-19. So can you speak to that a bit?
Yeah, so it wasn't much of a surprise when we saw the first signals. And again, the first signals came from the UK and the US. And I put a tweet out on the 1st of April 2020, because friends of mine said, we're seeing lots of young people, ethnic minorities in intensive care units. Kamlesh, do you know anything about this? So I put a tweet out, and I had a huge amount of views on it. But then as the data came out from particularly UK and then the US, it did show an increased disparities, but we weren't surprised. And the reason is pre-pandemic, there were a lot of publications showing, for example, there was less access to technologies in people with type 1 diabetes from ethnic minority backgrounds, insulin pumps, intermediate outcomes were poorer. US data showing Hispanics had much worse intermediate outcomes than the white populations. UK data showing high HbA1cs. Indeed, there's a systematic review showing that people from Black ethnic backgrounds were 30% less likely to have their HbA1c checked and the blood pressure checked as well. And then, as well as that, this data is showing some of the protective therapies like SGLT2 inhibitors are not prescribed to ethnic minorities as much as they are to white populations. And we showed very early on that even insulin wasn't as appropriately prescribed to people from particularly South Asian origin.
So clearly these disparities existed even before COVID-19, and I think COVID-19 has really brought out a lot of these. So in terms of what your group found, when you looked at the literature regarding ethnic disparities in COVID-19 outcomes now in people living with diabetes, what did you find?
It's a really complex area. It's very difficult to determine the key reasons. And so in the review article, we worked with people in the UK and people who've been working in the US in this area as well to say, what are the barriers or potential reasons for the increased disparities? And we came to conclusions that you could put them into 4 buckets. One is poor control measures. So this is where we say, there are language barriers, vaccine hesitancy, poor access to public health services. There may be poor uptake of screening, disadvantaged social environment, so poor working conditions, poverty, barriers to healthcare access, mistrust towards medical community, possibly structural racism, increased exposure. This is a big area. There's quite a lot of work that's been done. So this is key worker roles, people who work in healthcare, people who work in hospitality industry, they continued working and they were exposed. There's overcrowded multi-generational housing, so dense housing populations, you're more likely to spread the virus within that. There was increased contact with family members because ethnic minorities do have a greater contact with wider family members. Ethnic minorities always live in deprived communities. And again, this is an area that we saw an increased risk of COVID-19. And finally, the increased vulnerability. This is increased stresses within ethnic minorities. They have more comorbidities like type 2 diabetes. They have worse risk factor control, air quality, and biological differences. That's something that we've discussed in this review, but we don't have good data on that.
So maybe we can dive into that a bit because your review article showed that the data support there were differences from an ethnic perspective in terms of outcomes, worse outcomes for the COVID-19 disease. But I guess the question that often comes to me when I see papers like this, regardless of what therapeutic area, is how much is biology and how much is circumstance. And the reason I ask it is that a lot of these data are generated from Europe or North America, where obviously you have many ethnicities living together in society. But then do the data, let's say, coming from Africa, from India, from China, from East Asia, do those countries' data also show a difference in terms of mortality and morbidity from COVID-19 relative to other countries?
So when we look at Africa and India, for example, we did have a way where there's increased mortality rates, but overall, they weren't as affected as some of the other countries. Now, it's very difficult comparing countries because of the whole social structure of that country. The only way we can compare is where there are multi-ethnic populations, such as the US and the UK, where you have good data. Then you can compare between ethnicities. So, for example, we saw in the first wave, there was increased risk in ethnic minority group, both South Asians and Blacks. As soon as there was lockdown, the risks diminished. So it's likely to be more environmental rather than biological, we think. And biological area is, again, very difficult to, as you know, to research. There are some studies going on at, are there differences at cellular level, but I don't think that's the main issue. Our main issue, I think, is more structural reasons, environmental reasons.
I'm glad you pointed that out because that really then means there's a lot we need to do, right? Because if it's predominantly biologic differences, it's good to understand them, but we can't really change the biology per se. However, environmental, structural issues are definitely things that could potentially be changed. So along those lines, I mean, what are in your mind and your group's mind the next steps in sort of better understanding this important topic?
I think there's a number of things to do. There's a lot of research that's still happening at the moment. We need to continue that good quality research to get a better understanding of why not only people with diabetes, but people from ethnic minorities and people with diabetes and ethnic minorities get an increased risk and looking at potential causal pathways. But I think what we need to do now outside the research is plan for recovery. And we want to make sure that as we plan for recovery, not only do we reduce the disparities, but not widen them as well. And most of the work, again, our work and others, is showing that it's more the wider determinants of health, the societal changes that we need to do. So at population level, really, not something that you and I could do, but at population level, the governments really need to act on this. And this is where you improve housing, employment, schooling, education, food security, healthcare for the entire population. It's the deprived ethnic minorities who have poor access to all of this, and trying to level that up would be a good thing to do for everyone, not just ethnic minorities, but all the population, particularly the deprived population as well. As we open up, we want to make sure that we don't widen disparities, because we've now got things like telemedicine, telehealth. And there are barriers for some people, not just getting the technology, but also the language barriers. And we want to ensure that we don't widen the disparities by providing those type of technologies. We need to start having high quality education in a culturally appropriate manner for ethnic minority populations, just like we do for every person with diabetes. But ethnic minorities may not get the access to that culturally appropriate education programs, not just about COVID, but about management of their diabetes. We also want to start thinking about potential therapies. Randomized controlled trials, as you know, are mainly done in very white populations. When the results are published, you don't get the data for separately by ethnic minorities, but although some of the cardiovascular outcome trials are showing that. So are there signals that put people at higher risk or lower risk? And, we've seen from SGLT2 inhibitors that there may be a better impact in people from ethnic minority backgrounds with SGLT2 inhibitors. But these are just signals, but we need to do dedicated trials to do that as well. I think in a nutshell, there's a lot we can do both at societal level and us as a diabetes community as well.
Lots of great ideas for things that need to happen. Clearly, a lot of work that needs to occur, and I think the lessons that we can learn from this apply arguably beyond diabetes, beyond COVID-19. Right? We're sort of talking about the impact of environment and determinants of health, societal issues on really any chronic disease. You could probably translate a lot of the messages you said. So if society and governments try to level up, and I really like that language, sort of level up what's being done, the impact on the health of the communities, all the communities will really improve. And also, would you agree that these lessons could be then applied beyond North America and Europe, like beyond the multi-ethnic societies, but also to other countries where there may not be as many different ethnicities, but that the concepts of the social determinants of health and changing it would be helpful for those countries as well?
Absolutely. I think if we can show that we can do this leveling up by improving all the things I mentioned about housing, employment, etc., if we can get people out of poverty, that will lead to better outcomes. In fact, we've done some modeling within that, which is probably one of the papers that I'm really proud of. What we showed is if you move 25% most deprived population from deprivation, you reduce the risk of COVID mortality by about 50%.
Wow.
Remove 50% of the most deprived population from deprivation, then you really eliminate that increased risk in the deprived populations.
Wow. Wow. Thank you. Thank you for those very powerful data, and I think important messages for everybody who's listening. So I want to thank you. Thank you, Professor Kamlesh Kunti, for sharing your expertise with us today. Congratulations again to your group for having this feature article in the February issue of Diabetes Care. And I encourage all of the listeners to read the full article for further details. Thank you, Kamlesh.
Thank you very much, Alice.
Let's move on now to a segment we call Diabetes Care Rapid Exchange, where Mike and I get to chat about a few other articles we found particularly interesting. And Mike, as a side note, I feel like we need to come up with a jingle or something for this segment because we're going to keep doing this over and over. But let's go ahead then with our Diabetes Care Rapid Exchange.
All right. Thank you, Alice. So to start us off, debate continues over the importance of vitamin D sufficiency and supplementation for chronic diseases, including diabetes. Dr. Shui Chen and colleagues from Tongji Medical College in Wuhan, China, analyzed data from 14,709 patients with type 2 diabetes in the UK Biobank. They found, with more than 11 years follow-up, that increasing concentrations of 25-hydroxyvitamin D were associated with significantly lower risk of developing microvascular complications, including retinopathy, nephropathy, and neuropathy. Importantly, these associations were not modified by examining polymorphisms in the vitamin D receptor. Thus, these data provide further evidence in support of screening and supplementation practices aimed at avoiding vitamin D insufficiency for our patients with diabetes. But as pointed out by the authors, confirmation of these findings in a multi-ethnic population with diabetes is still required.
You know, it's been really interesting watching this vitamin D story over the last number of years, right? It's sort of been this pendulum that has swung back and forth somewhat. And I think this is another interesting piece to the puzzle. But if you ask 5 different people, you may get 5 different opinions on where vitamin D fits in. We all know the importance of timely eye examinations for people living with diabetes, but we also know that it doesn't always happen. So the next study I'm going to talk about is from Dr. Selina Liu from Western University in London, Ontario in Canada, and her colleagues. And they conducted a single-center randomized control trial comparing same-day on-site screening with non-mydriatic ultra-wide-field imaging. I got to tell you, that's a mouthful. On the day of scheduled diabetes clinic visit versus usual screening. And this specific outcome of interest was the detection of actionable eye disease. Now, out of the 740 participants, more actionable eye disease was detected with on-site screening with an adjusted odds ratio of 2.51. There was an impressive number needed to screen, and this really stood out for me. Their number needed to screen was only 13 over 3 years to detect one additional patient with actionable eye disease. So to me, this study is quite powerful. I mean, yes, it's single center, but it really just makes so much sense.
I couldn't agree more, Alice. It's great to see more evidence supporting this quite practical approach to reducing the burden of diabetic eye disease and making screening potentially more accessible and more frequent. LRG1 was recently shown to amplify TGF-beta-induced kidney fibrosis in animal models. Now, with this work done in humans, during more than 8 years follow-up, individuals with type 2 diabetes having the highest levels of urine LRG1 had an almost 2-fold greater risk of progressing to end-stage kidney disease. This finding is significant for the possibility that urine LRG1 may be useful both as a biomarker and also possibly representing a target of future intervention to delay kidney disease progression in diabetes. I look forward to seeing further validation and mechanistic studies on the role of LRG1 in diabetic kidney disease.
And this is pretty cool because we know the burden of diabetic kidney disease is really still quite substantial. So I think anything we can do to try to lessen that will certainly be valuable. So the next study is posing a very important question, which is to eat or not to eat, or perhaps it should be what to eat. And as you know, there's a myriad of information out there and sadly misinformation out there about the health impact of various food choices. And it's very challenging for all of us to navigate it. In this month's issue, Dr. Janet Barbaresco and her collaborators performed a systematic review and meta-analysis of prospective observational studies of various dietary factors and its relationship with all-cause mortality in type 2 diabetes. 107 studies were identified in total, and the greatest certainty of evidence, albeit still only modest, was found for higher intakes of fish, whole grain, fiber, and omega-3 polyunsaturated fatty acids, or PUFAs, as I like to call them. All of this was associated with lower all-cause mortality in type 2 diabetes. The other factors had limited evidence. So as I was reading this, I was trying to figure out, okay, so what kind of meal could one make that incorporates all of these components? And I'm picturing a walnut-crusted salmon fillet with quinoa for dinner. What do you think, Mike?
Oh, that does sound delicious, Alice. And certainly healthy food can indeed taste good. However, healthier food choices typically cost more and often present a barrier for our patients trying to modify their diets for health benefit. So in this month's issue, there are also 2 reports from the Search for Diabetes in Youth study that address household food insecurity. In one, Dr. Faisal Malik from Seattle Children's Hospital and colleagues identify that household food insecurity affected nearly 1 in 5 youth and young adults in diabetes in the past year. This is a significantly higher prevalence than that observed in the general U.S. population. Although what was consistent with the U.S. general population is that in this study, household food insecurity rates for non-Hispanic Black participants was nearly twice that of non-Hispanic white. And that was especially true among those individuals who had type 2 diabetes. And so addressing household food insecurity for individuals with diabetes in the US is also going to require addressing existing racial and ethnic inequities.
Excellent study that you pointed out there, Mike. A very important topic as well. And along the lines of lifestyle, let's talk a bit about physical activity. Now, I think it's common knowledge. Everybody knows that physical activity is good for you, but everybody also knows that it's easier said than done. And if anyone needed an additional reason to increase physical activity, we can now add atrial fibrillation to the list. Dr. Chan-Soon Park and colleagues conducted a nationwide longitudinal follow-up cohort study of 1.8 million subjects in South Korea. Over a mean follow-up of 5.6 years, they were divided into 4 groups. And I want everyone listening to put themselves into one of these groups. So they were divided into 4 groups: persistent non-exercisers, new exercisers, exercise dropouts, and exercise maintainers. Now, as a side note, 65% fell into the first category of persistent non-exercisers. So clearly, still a lot of work for many people to do, including myself. Now, they ultimately found that any exercise is better than none, with the lowest risk in the exercise maintainer group with a hazard ratio of 0.91. And again, remember, this is for atrial fibrillation. Now, the amount of exercise needed was also defined. So greater than or equal to 1,500 MET minutes per week in the new exercisers, and greater than or equal to 1,000 MET minutes per week in exercise maintainers, which translates to about 4.5 hours of walking per week. So yet another reason to get moving.
Yes, Alice, and that must be my cue again that it's time for me to get to the gym. Well, there's a sample of what's in the February 2023 issue of Diabetes Care. Please check out the full issue for more.
And a huge thank you to Drs. Kemlesh Kunti, Michael Schwartz, and Jamie Crinsley for sharing their insights with us.
And a reminder to everyone to submit their original art for consideration to be included on a future cover of Diabetes Care. And a big thank you to all of you for tuning into this episode. We welcome your comments and feedback, and don't forget to subscribe to this series and get notifications when a new episode comes out. Thank you for listening.